Hello, everybody. Dear colleagues, I welcome you to this online course, Challenges in Diagnosis and Disease Management of MPS and Alpha-mannosidosis. Extremely rare diseases, this I have to admit, but diseases that are treatable. And this is why it is important to know about and to be aware of. So we start the first module in Introducing MPS and Alpha-mannosidosis, Challenges in Diagnosis and Disease Management. And my name is Dr. Christina Lampe. I'm the director of the Center for Rare Diseases at the University in Gießen at the Department of Child Neurology. And now let's start the session. Just a few notes before we start. Please do not take any screenshots. Please do not reproduce any slides or content of images. The format will be 60 minutes, split into two parts. So 20 minutes for the first presentation, 10 minutes question and answers. So you have a chat where you can answer all your questions you have, and I will answer the first part after the first 20 minutes of presentation. And then we have another second part, and after that there will be a question and answer session again. So please submit your questions via text and not verbally. And whenever there's time enough, I will answer as best or on my best to have your questions. So let's start part one, introduction and overview. What is MPS and alpha-mannosidosis? How to diagnose MPS mannosidosis early, so the earliest signs and symptoms, which is the most difficult part, I have to say. Then exploring the latest diagnostic options that are available. And the third part will be reviewing the pathophysiology. So I want to start first with a lot of pictures so that you get an impression of this disease and why it is so important or difficult actually to recognize MPSs in practice. And what you can see here on the pictures, and these are some examples of MPS patients, that this fast progressive or so-called classical MPS patients, it is in a way obvious that something is wrong with these children, but they are already at an older age. And it is something that you will start any diagnosis for sure. In other cases, in these patients at the same age, but in a more slowly progressing disease or non-classical disease, it is much more difficult to make a diagnosis because there's not obvious immediately that something is wrong with these children. And you may think probably they're just a little bit different from others. So, but these have the same disease. And if these patients are actually adults, it is extremely difficult to make any diagnosis because then they are not under the care of pediatricians anymore, and adult physicians are not that much aware of these diseases of childhood, genetic diseases, inborn errors of metabolism. So at this point, these patients have often misdiagnosis. So it is important that you as a pediatrician diagnose this patient as early as possible. And to show you that these patients are really very similar to other skeletal dysplasias, here are some pictures of patients. Some of them are MPS patients, so mucopolysaccharidosis patients, metabolic patients, but they are also part of the 460 skeletal dysplasias that we know. And you see here how difficult it might be to diagnose. So how to diagnose early? The major problem is that if you see the earliest signs and symptoms of MPS and mannosidosis, they are very similar to common complaints that you have to deal with as a pediatrician. For example, you have a child visiting you with recurrent infections of the ears and airways, or you have a child visiting you with hearing loss or with umbilical or inguinal hernia, or a child that seems a little bit stiff in a way or has some developmental delay. So nothing really to be concerned about, I think, correct? But how about if these infections are much more frequent or severe than usual? Or how about if this child has additionally an hearing loss, or additionally an umbilical hernia or inguinal hernia? Or if this child, additionally to this more frequent and severe infections, it seems to be stiff or in a way delayed in diagnosis. So you have the impression that something might be wrong. So what do you think and what do you do actually? And to give you a very typical example of a patient with a mucopolysaccharidosis, that might be a mucopolysaccharidosis, but also from the earliest signs and symptoms, Alpha-mannosidosis, I will show you a video about one child with Hunter's disease.
Februar 2010.
This is a child that is born from German and Spanish parents, normal height and weight at birth, uneventful pregnancy, and he was dismissed from the hospital without any pathological findings, beside the slightly enlarged head circumference. You see him here, looking extremely healthy and like a normal baby. Oh, I'm sorry for that. I will start the video again. You see him here in his first week, and he looks absolutely nice. The parents actually saw his first smile in his life at the second week. You see him here. And please check a little bit if you see the parents in the background and compare it to the appearance of the child, and also check how the child is moving. If he looks a little bit stiff. With 5 months here, the child had an inguinal hernia and needed an operating surgery to solve this problem. With 5 months, 7 months, he was able to sit, and with 9 months, he was able to turn around alone. With 9 months, he started to speak with yay, yay, ya, ya. So the typical first sounds of a child. With 10 months, he had a severe infections of the airway. He needed antibiotics, and after 2 weeks, he had another infection and needed antibiotics again. With 11 months, you see him here with the mother. He is a healthy-looking child. The only thing was that his head circumference looked a little bit big, and the mother was concerned that he was not really starting to speak. So he started here with his parents, saying mom and dad, but he was not really trying to speak properly, even if he tried to communicate very much. Here with 15 months, you see him walking his first steps, so absolutely in time. And here he wanted to take some toy, and you see that he had problems in moving his shoulder. So in a way, stiffness. With 18 months here, he could stand up alone. You see the enlarged abdomen and the umbilical hernia. And with 19 months, he was able to eat alone. The parents were very concerned about the fact that he had an enlarged head and also that he was not speaking, and they were had the impression that he had a hearing loss. So he went to an ENT. The ENT diagnosed some fluid behind the eardrum, and due to the recurrent infection that he had already, the ENT had the suspicion that this child needs an adenoidectomy because he was also not sleeping properly, had a lot of snoring and apnea during night, and also some T-tubes. So they performed a hearing test and showed a severe hearing loss on both sides. The mother was pregnant that time, so she was very concerned about the situation of the son and wanted to get a diagnosis. So this child had an ENT surgery with adenoidectomy and also T-tubes, but unfortunately, the child or the hearing test after was not really showing any benefit. So I just show you a little bit more pictures. With 27 months, he went to the kindergarten. He was still not speaking properly. And with 28 months, look him here, when he's moving very shortly, in a way, he looks stiff. The spine looks extremely flat, and he's not really flexible and mobile that you would expect in a 28-month-old child. He had at this point also the umbilical hernia making trouble and another inguinal hernia on the other side that needed a hernia repair. Just to go a little bit, he's on the beach. The parents were concerned about his sleeping because he was waking up several times. He was still snoring. He had apnea, and he was not really healthy. So the parents went to a pediatrician, and the pediatrician said that the head circumference is okay. It is a little bit enlarged, but nothing serious. And she did not say any. She did not saw any reason for further diagnostics. but the parents insisted on having some developmental delay testing and also to go to a neuropediatrician or child neurologist to understand what is going on with the child. This child neurologist had already seen once an MPS patient, and due to that, she started to make some diagnostics. Unfortunately, it was summertime in Spain, and the physician or the diagnostics took extremely long. And for this reason, it took quite long after until he had a real diagnosis. And with that picture, I want to stop the video and just summarize for you the signs and symptoms that we had so far. The diagnostic was then done in Germany because there was a geneticist, also the neuropediatrician knew about the MPS disease and mannosidosis, and the diagnostic was done. So just to summarize, the pregnancy and birth was absolutely normal in that child. He had just this slightly enlarged head circumference. His development was normal. He had, with 5 months, an inguinal hernia on one side, with 2.5 years, adenoidectomy and T-tubes, and also an inguinal hernia repair on the left side. Additionally, at this time, he had a delay in teething, enlarged head, language delay, also due to the hearing loss, and always recurrent severe infections of the airways. And you see also here on the pictures how he changed his face. And also the parents were concerned because he looked totally different from the family. I said already, with 1.7 years of age, the an ultrasound of the head was done, and the pediatrician saw no reason for further exams. And at the age of 2.5 years, there was the first visit at the child neurologist. And the diagnosis at this time was global developmental delay, in particular language developmental delay. So extremely unspecific, but it could be also a multisystemic disease. And the child neurologist had already the idea. And she started to make some tests, some urine tests, I will explain later, to get an impression whether this could be an MPS or mannosidosis. She made some enzyme activity testing in blood because MPS and mannosidosis are diseases with a deficiency of a lysosomal enzyme, and also a genetic confirmation of the disease. So what is it now so difficult to make an early diagnosis in children with MPS or mannosidosis? The major problem is the earliest signs and symptoms show overlap with very common complaints in childhood, like frequent respiratory infections, ear infections, hernia, developmental delay, hyperactivity. It could also be a diarrhea or heart murmur. So what you have to do to get a diagnosis, because there's no specific earliest sign and symptoms of MPS and mannosidosis, but a combination of these symptoms could lead to a suspicion. So a lot of children should be tested. To describe MPS and mannosidosis very rough, it is a multisystemic disease. It is a genetic disease. It's chronic progressive. This is an important fact to have to take into consideration if you deal with these children. The appearance is extremely heterogeneous and it is life-threatening. But important is, even if these diseases are so rare, we have for some MPS types and for mannosidosis a treatment available. And you don't want to miss any treatable disease in your practice. It is a multisystemic disease, I told already, and the signs and symptoms are here described with a lot of pictures of MPS and mannosidosis children. And what we see is the face has a coarse face. So you see it when they are older, the appearance is showing that something is wrong with the child. They have a hepatosplenomegaly, inguinal and umbilical hernia, sometimes swallowing problems. The lung has obstructive and restrictive lung disease, the recurrent infections that makes a lot of trouble. They have narrowed airways. Think to anesthesia, and these patients, very difficult topic. They have skeletal problems, and this is also why the MPSs and mannosidosis are part of the skeletal dysplasias, not only a metabolic disease, with hip dysplasia, kyphosis, contractures, a kyphoscoliosis in the thoracolumbar spine, could be the first symptom for an MPS disease. They have an eye involvement with the typical symptom corneal clouding. The ears are affected with hearing loss and recurrent infections, but also the heart valves are involved, especially in MPS, not that much in monocytosis, and the CNS in some patients. 60% of patients with monocytosis and MPS have an involvement of the CNS due to the storage of material in the brain. And this is actually the one of the biggest topic of these patients. 60% have a CNS involvement with a cognitive decline, but others don't have. I said already, MPS and monocytosis are extremely heterogeneous, which means the variability of signs and symptoms. Not all children show all or present all signs and symptoms that I showed before. They have a wide spectrum of disease severity. I will show you another picture. And the disease severity in specific organs may differ from one patient to the other. So it means MPS or monocytosis patients have their own disease. Each patient has his own disease, and this makes it extremely difficult and variable in the clinical picture of these patients. And especially if patients have no cognitive involvement, it is even more difficult to diagnose. Here it is in the upper part of the slide. It is an example from the literature of an MPS 1 patient that has a very slow progressive disease. But what it shows that even if the child at the age of 4 years and the young lady at the age of 24 years look absolutely healthy, the storage had already begun. And you see with 31 years of age and with 54, she's in a wheelchair. So it means even if the disease is slowly in progression, she has the same complications of the disease than more severe patients. So this means also these patients should be diagnosed and treated. And actually, in the lower part of the slide, you see a 6-month-old MPS 2 boy looking absolutely healthy and fine. And at the age of 30 years, you see the severe storage in the face. But this is not only in the face, but this happens in all organ systems, even if they appear normal at birth. And this is the way of this disease. To make it a little bit easier, before I tell you about the pathophysiology and how to diagnose these patients, you see a monocytosis patient that is also called Hurler-like syndrome. Hurler is the severe form of MPS 1. And you see also, I divided them in the stiff ones and the hypermobile ones, and also those with cognitive loss of cognitive abilities. The MPS 1, 2, 6, and 7 patients, they look very similar in the green, in the yellow frame. And I call them the stiff ones because what you see are the contractures of joints and the enlarged abdomen with the umbilical hernia and the short neck. In contrast to them, the hypermobile ones, the MPS 4A and B patients, they are the same group of disease, but they have a hypermobile joint and more musculoskeletal disease, while the MPS 3 patients have a loss of cognitive abilities in childhood and have less severe physical involvement of the disease. Just to show you some pictures of the more mild and severe patients, so the disease severity, I will give you some short introduction to these diseases. For alpha-mannosidosis, we have a very mild form with a very slow progression and juvenile onset. We have a moderate form with a juvenile onset and slow progression. And we have a severe form that starts in infancy and has an important CNS involvement and early death. And you see some pictures here. But there's a treatment available, the enzyme replacement therapy. So the missing enzyme is replaced with an IV infusion every week. The spectrum of the disease severity in MPS 1 is shown here. And important is that MPS 1 has one advantage in contrast to the other MPS types. The advantage is that if you diagnose an MPS 1 patient with a severe disease under the age of 2.5 years, there is a stem cell transplantation or bone marrow transplantation possible that is stopping the cognitive decline in these patients. So this is why it is extremely important to diagnose early. So stem cell transplantation is a treatment option for MPS 1 patients if you diagnose prior 2.5 years in life. And then you can stop the cognitive decline in these patients. But we have also patients in MPS 1, the shy patients, that are without any cognitive involvement. And actually, in former times, before the reason or the cause of the disease was described, the enzyme deficiency, they were thought to be another type of MPS, the MPS type 5. Now we don't have MPS type 5 anymore because the enzyme deficiency is the same from the severe and also the attenuated types. Another MPS type is MPS type 2. It's the Hunter syndrome. You see, we have patients with cognitive and without cognitive involvement. Important in this Hunter syndrome is that beside all other MPSs and also mannosidosis, MPS 2 is the only X-linked disease in this group of diseases. So MPS 2 is X-linked. The mothers are carrier and the boys are affected. And they have no corneal clouding, which is a very specific symptom for MPS. A child with corneal clouding, you should think to MPS. In MPS 7, an ultra rare type of MPS. You see here the spectrum of the disease. There is a treatment available as well, the enzyme replacement therapy, like in Hunter syndrome and MPS 1. And typical here is that some of these children have a hydrops fetalis when they are born. And this should always lead to a suspicion to test on MPS 7. I told already, Sanfilippo syndrome, or MPS 3, is a group of 4 different enzyme deficiencies that have mainly progressive cognitive decline in childhood. So there is so far no treatment available, but there are some clinical trials on the way, and they have neurological problems, seizures, behavior problems. Now we are entering the Morquio syndrome. MPS 4 or Morquio syndrome is a mainly musculoskeletal disease. They have the hypermobility of joints in contrast to all other MPSs that are more stiff and have contractures. They have this specialty that they have an atlantoaxial instability, which makes anesthesia complicated as well. And also here, there's an enzyme replacement therapy available, at least for MPS 4A, I'm sorry. MPS 4B is not treatable. And spectrum of the disease severity of MPS 6, you can see here from fast progressive to slowly progressive. They have no cognitive involvement as the Morquio patients. MPS 4 and MPS 6 are the only MPS types where you have never a cognitive involvement. And I will explain you a little bit later why. These patients have an enzyme replacement therapy as well. You see, due to this disease severity spectrum and the heterogeneity of these diseases, it is extremely difficult to diagnose. And what you can see that in literature, we have indeed a median delay of diagnosis of 3 years. In MPS 3 and 4 patients you see here on the picture, it is also 6 years. So it is a big gap between earliest signs and symptoms in early childhood in the first 2 years of life and the diagnosis that is done much later. So how to diagnose these patients now? The screening test that is possible and easy to do is to measure the oligosaccharide excretion and the glycosaminoglycans for MPSs in urine. Unfortunately, this is not a really confirmation of diagnosis because we have false increased excretion, but also normal GAG or oligosaccharide excretion in urine, even if it affected children, which means this test is a good screening method, but it is not confirming or not making any diagnosis. The gold standard to diagnose these patients, because we are talking about rare lysosomal diseases, we are talking about enzyme deficiencies that are leading to storage in all organ systems. And this is why the enzyme activity testing in blood or fibroblasts is the proof of diagnosis. So whenever you have a patient and you have a low enzyme activity for different enzymes, you confirm the diagnosis of mannosidosis or MPS. We have a genetic testing, which is confirming the diagnosis and can also make diagnosis, but not all mutations that are leading to MPS and mannosidosis are described in literature. So this is why you can have false negative results with genetic testing, because not all mutations are found. The prenatal testing, if you have genetic testing in one affected child, is possible. And the easiest option to diagnose MPS or mannosidosis is the dry blood spot testing. It is so far not available, or not in all countries available, for alpha-mannosidosis, but it is on the way. And we have dry blood spot testing for MPS 1, 2, 3A, 4A, 6, and 7. And this is only 5 drops of blood on a filter card. You send it away and you get a result. It is extremely specific, but it is, it is extremely sensitive. So you will not miss any patient, but it is less specific. So you have false positive testing. So this is why the real confirmation has to be done by enzyme activity testing in fibroblasts or blood, or with genetic testing. So what is the pathophysiology? I talked so much about these diseases, but I never said what it is the reason or the cause of the disease. And actually we have 6,000 genetic diseases. We have 600 metabolic diseases, 60 lysosomal diseases or storage diseases, and 11 MPS deficiencies leading to 7 types of MPS and an alpha-mannosidosis. And you see here that all the lysosomal diseases, the red one surrounded diseases, are diseases where we have a treatment, and the blue ones where we have a treatment on the way. The pathophysiology is easy. It is the dysfunction of at least one lysosomal enzyme, and this is leading to the accumulation of products that should be recycled or cleaned from the body. But this storage of, in MPS, glycosaminoglycans, or in mannosidosis, oligosaccharides, are leading to a cell dysfunction and cell death. And since we have everywhere in our body glycosaminoglycans and oligosaccharides, all organ systems are affected. For example, glycosaminoglycans are the main component of the extracellular matrix in the body. So glycosaminoglycans are everywhere. And if you have a storage everywhere in your body, it is clear that you have a multi-organ involvement. And here on the picture on the right side, you see a cell with all the white bubbles that is storage material. And I think it is obvious if you see that cell, that this cell is not working properly anymore. To show you the classification of MPS, because in alpha-mannosidosis, it's one disease. We have a deficiency of alpha-mannosidase and storage of oligosaccharides. In MPS, it is a little bit more difficult because it is not one disease, but these are 11 known enzyme deficiencies that leading to storage of different GAGs and to 7 main types of MPS. And as I said before, not all of these patients have a cognitive involvement. So these patients where the glycosaminoglycans are stored, heparan sulfate, one glycosaminoglycan, that I here used HS to show it. We have it at MPS 1, 2, MPS 3, and also MPS 7. And these are the diseases that are storing heparan sulfate, and for this reason may have or can have CNS involvement, because the heparan sulfate is the cause of that. So again, just to summarize, we have the alpha-mannosidosis that looks like a severe MPS 1 patient. We have the 7 types of mucopolysaccharidosis, the stiff ones, MPS 1, 2, 6, and 7. We have, in contrast to that, the hypermobile ones, the MPS 4A and B patients that have the hypermobility of joints. And we have the third group, the MPS 3 patients, 4 different enzyme deficiencies that are leading to a loss of cognitive abilities in childhood. And now to prove, or for you also to see whether everything I told you was clear before you can ask your questions, I would like to start with one question. So what is correct? Mucopolysaccharidosis and mannosidosis are multisystemic diseases, extremely heterogeneous, have always cognitive involvement, are due to different lysosomal enzyme deficiencies, and are metabolic diseases and skeletal dysplasias. What do you think? I will show you the answer immediately. So what is correct was the question. For sure, they are multisystemic and extremely heterogeneous diseases. They have not always a cognitive involvement. As I told you, MPS 4 and 6 patients never have. And there are also some patients that have sometimes an involvement and sometimes not. So not all patients have a cognitive involvement, but they are due to different lysosomal enzyme deficiencies. This is correct. And they are metabolic diseases, enzyme deficiency, but also skeletal dysplasias, as I showed you at the beginning. So number C is correct. Question 2, what is wrong? The question, what is wrong? Mucopolysaccharidosis and mannosidosis have specific early signs and symptoms, are easy to diagnose, have kidney involvement, have sometimes hearing loss as first symptom, or symptoms overlap with common complaints in childhood. So what is wrong? So what is wrong? They have no early sign and symptom that is specific. This makes it so difficult to diagnose. It is not easy to diagnose. This is the next. And actually, nobody knows why, but MPS patients have no kidney involvement. For sure, they have sometimes hearing loss as first symptom, and the symptoms overlap with common complaints in childhood. This is correct. And the last question before you start your questions, and again, what is correct in mucopolysaccharidosis and mannosidosis? Glycosaminoglycans or oligosaccharide excretion in urine can be normal. Enzyme activity testing in blood is the gold standard of diagnosis. Genetic testing is useless. Dry blood testing is very sensitive but less specific. And only from the appearance, the different types of MPS can be diagnosed. Make your guess. Okay, what is correct? For sure, glycosaminoglycans and oligosaccharides excretion in urine can be normal. This is what I explained, that it is only a screening test and not a confirmation of diagnosis. The enzyme activity testing in blood is the gold standard. This is correct as well. Genetic testing is useless, is a stupid sentence for sure. And dry blood spot test is very sensitive, but less specific and need a confirmation of diagnosis. This is correct. And it is totally wrong that only from the appearance, the different types can be diagnosed, even for an expert. It is impossible. So now I'm waiting your questions and answers. I hope that a lot of people will be very interactive. And here I see already the first questions and the question is, do these children have the same facial appearance at birth, or their facial features become more evident while they are growing up? And I think I showed you the MPS 2 boy looking absolutely healthy at the beginning, and also the video showed the child being absolutely healthy at the beginning, and over the time, you saw the face that was changing, and you saw the storage in the face. So it is absolutely typical. An MPS child is healthy looking at birth, very proper, very nice children. And over the time, you see the change of the face, the coarse face, due to the storage. Next question. Any further question? The next question is, are these now metabolic diseases or skeletal dysplasias? And actually, they are both. They are part of the skeletal dysplasias. Skeletal dysplasias are divided in 40-something groups of different diseases. And one group is indeed the lysosomal storage disorders with dysostosis multiplex. So dysostosis multiplex is the typical radiological signs and symptoms of MPS and mannosidosis patients. So it is the hip dysplasia, the thickened skull, the shortened long bones, the shortened and thickened middle hand and middle feet, the ovoid vertebrae. So these are typical signs of MPS. So MPSs are metabolic diseases because it's an enzyme deficiency disorder, but they are also skeletal dysplasias. Any further questions? Do have patients with cognitive involvement also a benefit from ERT treatment, although the enzyme is not crossing the blood-brain barrier? This is a question I will answer a little bit later because I will explain first. So any further questions? Are there any specific genetic mutations or enzyme activity that correlate with a cognitive spectrum of MPS II? There is no clear correlation between mutation and cognitive involvement in MPS II. For sure, very severe mutations or big changes or mutations make more severe phenotypes, but there's not, like in MPS I, we have a better genotype-phenotype correlation. In MPS, it is not completely clear, but there are some mutations that indeed lead to a severe phenotype. Any further question? Is there any test that can be done during pregnancy? Unfortunately, you cannot make a diagnosis of for sure, you can measure in the amniotic fluid, you can measure the enzyme activity. But actually, if you don't have any case or any patient in your family, it is so rare, the disease, that it is not part of the usual screening testing. But if you have one patient in your family, a cousin or a sibling of the unborn child, the best would be to make a chorionic villi examination if you have a genetic result of the affected child, because then you can look for this mutation. The amniotic fluid is also possible. You can measure the enzyme activity, but you have to grow the cells for a few weeks and also to wait the result. And so the pregnancy is already in a higher status, or it's around the 20th week of gestation, and then it is very difficult to decide what you want to do with the child. So the chorionic villi examination with the genetics, it's the best, actually. Any further questions? What about the DBS for alpha-mannosidosis? This is already on board, and where, so far as I know, I am in Germany. What I can tell you that we don't have it by now, but we are waiting for that. So it will be possible. There's one lab in Germany that is already offering the dry blood spot test for mannosidosis, but not in general. But I hope and I think that it will come soon in a lot of countries, because it's really the easiest way to diagnose. Any further question? How is MORCHIO treatment executed? I don't understand the question exactly. If the question is what is the expectation of MORCHIO for a treatment, I can say that there is indeed also in the trials that are over 2 years, there is a benefit in endurance, in pulmonary function, also in quality of life, but it is not, we have the treatment since 2014, so it's only a short period that we are overseeing. Also, it seems that patients are growing better, so which is another benefit. They have less infections. So it is a treatment that is indeed working, but not available in all countries, unfortunately. Are siblings having similar clinical features? Yes, they have. Although I have to say, if you have siblings, one is always a little bit more affected than the other. But also in this case, since we have the treatment, one starts always earlier than the other or at younger age. And I will show you very soon an example how different it is if you start early or later. But for sure, we don't have one very severe affected child and with the same mutation, a very, very mild affected child. So they are similar, but not absolutely clear, because as I said, every patient has his own disease. And I think we have to go to part 2, otherwise we will be longer than 60 minutes. And I will start with the next part, the red flag signs and symptoms, the basis of diagnostic, and when to suspect. So we start with examining the multisystemic features of the disease. I will show you a lot of pictures and a lot of slides, so just focus on the pictures that I show. Reviewing how is the best follow-up for these patients and what is the treatment that is available for these patients. So why we have to diagnose early? This is the first question I want to ask. And here it is, what does it mean for undiagnosed patients? Undiagnosed for a patient means looking always to get a diagnosis, to get a treatment, to link to an expert, to link to other affected families, or patient associations, to think to family planning. If you don't know what disease your child is suffering from, you don't know actually how will be the situation for further children. So you have an uncertainty, and also mistreatment is absolutely normal in undiagnosed patients, because not all treatment options are the best for each disease. And also you cannot detect the life-limiting disease complications if you don't know which these are, and also the quality of life limiting disease complications you don't treat because you don't know what you have to look for. So for a patient, it has a big, and the families has a big benefit to have a diagnosis. The second reason is the storage begins prior birth, as I told you before, and this is confirmed in human fetuses with MPS 2. So it means even if the child is born and looking absolutely healthy, in the storage had already begun. The third reason why to diagnose and also start treatment early in MPS and mannosidosis patients is that MPS and mannosidosis are progressive. And I showed you already these pictures, and I would like to highlight again that this is happening in all organ systems. So if you start a treatment and you have irreversible organ damage, the irreversible damage is there, but what you want to do is to avoid any irreversible organ damage. And what we know for the treatment is, here's an example for MPS 2, but it is also published for MPS 6, that we have in treated patients a better survival. And here it is demonstrated in almost 1,000 MPS 2 patients that they have in 54% a lower risk of death in the treated patients, and a lifespan that is 10 years longer in treated patients than in untreated patients. And here's the case report that I was referring to. The patient 1, he started at the age of 3 years of age with enzyme replacement therapy. So the missing enzyme was substituted. He had all organ systems affected, as you can see here, before ERT, and after 3 years, he was checked again. And what you can see after 3 years, he stabilized in a lot of signs and symptoms, or he improved also in hepatomegaly for sure, for example, and not very much in the skeletal involvement, the dysostosis multiplex, which is obvious because it is a less vascularized tissue. But if you compare it with his brother, who started at the age of 4 months, he was diagnosed because of the disease of the brother with enzyme. He had no signs and symptoms when he was born, as we said before. And after 3 years on treatment, you see that he still has almost in all signs and symptoms no involvement beside the skeletal part, which shows that the earlier you start, you avoid irreversible organ damage and you avoid signs and symptoms. But now, what treatments are available in these patients? Actually, you have to check all organ systems in these patients. I said already, the life-threatening disease complications, the CNS, the respiratory system and the heart, and also the quality of life reducing disease complications in these patients, the skeletal, the eyes, and the ears. Who cannot see properly and not hear properly, cannot develop properly, and they have a really limited quality of life. Also, mobility is a big issue, especially in MOCU patients. So this is why we should really take care of that. And you have a lot of exams that could be done to check these organ systems. And I will show you later a recommendation how to do it. So what is needed is a lot of specialists to treat these patients. And now let's see what quality of life reducing disease complications we have in skeletal, ENT, eyes, and gastrointestinal involvement. I would like you to now concentrate on the pictures, not very much on the text. So for the skeletal and joints, what we need is we need imaging, we need joint range of motion measurements, and we need orthopedics that are taking care of these patients. We need a lot of physiotherapy. There are some surgical procedures that are really helpful in these patients, but also orthosis or insoles or corsets that can really help these patients. But most important is the physiotherapy. From the craniofacial, ENT, eye and teeth point of view, we have to treat the deafness of these patients with hearing tests, T-tubes, adenoidectomy, hearing aids. The recurrent infections have to be treated very aggressive, also with antibiotics, inhalation, T-tubes if needed, and so on. Adenoidectomy, tonsillectomy, extremely frequent in MPS patients and needed also for a good sleep. And the eyes are involved with corneal clouding, visual impairment in MPS 6, for example, also glaucoma, or in mannosidosis, strabism. Very obvious things. Gastrointestinal, we have the hepatosplenomegaly, but this has no therapy needed because hepatosplenomegaly is absolutely without any restriction in the function of these organs. So it is just big, but the function is perfectly fine. Umbilical and inguinal hernias need surgery, and the diarrhea needs to be treated with medication if needed. The behavior and probably cognitive decline in these patients that we have in 60 to 70% of patients that I said already, like hyperactivity, aggression, motor decline, abnormal gait. This is something we can try to treat with medication. The sleep disorders are a big problem in these patients and also lead to an impairment of the cognitive situation and the hyperactivity of these patients. So sleep is extremely important in these patients. So perform polysomnographies to detect sleep apnea and sleep problems to treat that, also with medication or with CPAP ventilation during night. Very important also for the behavior. And you know, children that don't sleep properly are not in a good mood the next day. Seizures are one topic that need to be treated, and also hydrocephalus or spinal cord compression are big topics in these patients. What is the life-threatening disease complication in these patients? We have the cardiac involvement, the pulmonary, the airway infections, and the CNS, the craniocervical stenosis. And as we said with the ENT system, also here the frequent infections of the airways need inhalation, antibiotics, physiotherapy, and also surgical interventions to solve the problem. We have the restrictive lung disease due to the small and very stiff rib cage in these patients. I don't know whether you have seen, but most of these patients have a very short trunk and long legs and arms. So the rib cage is extremely small, and the enlarged abdomen also gives not very much space to the lung, and the lung cannot really work properly. So this is why these patients really need a lot of help and physiotherapy also to to deal with the lung disease. And actually, the cardiorespiratory complications is the main cause of death in these patients. In MPS 3, also the pneumonia. So this is why the pulmonary system has to be checked and has to be treated aggressively. Heart insufficiency is not that much often, but heart valve disease and heart valve insufficiency, and also arrhythmias. So you have to check regularly the heart in these patients. And I told already, and I would like to highlight again, be aware that MPS and monocytosis patients have, due to the narrowed airways and the thickened tissue of the airways due to the gag accumulation, they have a high anesthesia risk in intubation, but also in extubation. So you need an anesthesiologist who is very aware of these complications and knows how to deal with these complicated diseases. We have problematic upper airways. We have in some patients, as I told already, the atlantoaxial subluxation or instability in the cervical spine. And we have also the heart involvement and the pulmonary disease and the difficult positioning. So the best would be a fiber optic intubation, awakened fiber optic intubation, or local anesthesia. The CNS and peripheral nerve manifestations, I told already about hydrocephalus, spinal cord compression, atlantoaxial instability that need imaging for sure, and sometimes surgical intervention. But we have also, and this is something very special for monocytosis, not, but for MPS, the carpal tunnel syndrome. Carpal tunnel syndrome is extremely rare in childhood, but if you find a child, as you see it on the picture on the left side in this boy, with the carpal tunnel syndrome, you should think to monocytosis, to MPSs or mucolipidosis, because this is usually a complication of middle-aged people. The carpal tunnel syndrome does not make the typical signs and symptoms like shaking the hand or tingling in the fingers or paresthesia. They are much more slow in progression. So it means the patients don't really feel the loss of sensitivity in their fingers. So this is why you need nerve conduction velocities in your patients to detect. So now, what is the best follow-up for your patients and the immediate next steps? And actually, there is, for sure, we are not talking about one disease. We are talking about monocytosis and 7 forms or types of MPS. So it is difficult now to show you all what is on the literature at the moment. But what I can recommend, and this is a new guidance to manage MPS 4A and 6 patients, so the hypermobile ones and the stiff ones, in the web. This is published this year, and it is actually a consensus of experts dealing with MPS patients, and this consensus, due to online surveys and so on, was a modified Delphi procedure that lead to a lot of very good key messages how to deal and how to treat MPS patients. And one of these is that at diagnosis and regularly after, patients should be followed to ensure that they are receiving optimal care. And this first step is, whenever you have a patient, whenever you want to start a treatment, you have to perform baseline assessments. The baseline assessment should include endurance, growth, the urinary gag levels for sure, the respiratory function, quality of life questionnaires, but also evaluation of the upper and lower limb function and the cervical spine. This means whenever you diagnose a patient, you start from that, because then you have a good basis for regular follow-up examinations and you understand what is going on in these progressive diseases. In this recommendation that was recently published is also a list of all assessments that are needed and how often to perform them. For example, MRI of the whole spine. In some cases, if there's a problem, you would do it every 12 months. But the 6-minute walk test was the best test and also was primary endpoint in the clinical trials in combination very often with the pulmonary function. So endurance and pulmonary function were mainly the primary endpoints in the phase 3 trials to get approval for the enzyme replacement therapies. And these have to be done very regularly, every 6 months, for example. But you can see in the guidelines. They have also, the guidelines give some recommendations about which surgeries are good options for or optional for MPS patients. And they also give you some ideas when you send your patient to an ophthalmologist, what you have to ask this specialist for. So you have to ask for intraocular pressure, you have to ask for the retina, you have to ask for a split lamp examination to see the corneal clouding, because if the other physician is not aware of MPS, he doesn't know what to look for. So also these guidelines give you some ideas what you have to ask for when you send a patient to another physician. So now the latest treatment option. I told already that MPS 1 is the one with the stem cell transplantation option under the age of 2.5 years and stopping the cognitive decline and also some physical aspects. We have the enzyme replacement therapy, so giving the enzyme to the patient IV. We have the symptom-based patient therapy that is important for each patient, and there are also some new therapies on the way, but I cannot talk about that in that frame today. So the enzyme replacement therapy, and I show you here the small vials of the treatments that are available in some countries. We have the decrease of urinary gag excretion and reducing of liver and spleen volume. This is both things have no impact on the patient's quality of life on ERT, but it shows you that the enzyme is given and it is working in the body because you have a normal gag excretion in most patients that receive enzyme replacement therapy. We have an improvement in joint mobility, which is true, but since this is a less perfused tissue, it takes quite long. But there are studies, long-term studies, especially in MPS 1, showing how much improvement you can see over the years in joint mobility in these patients on ERT. The pulmonary system and endurance is improving. These were mainly the primary endpoints of the clinical trials. And the skin and hair is improving. And also there is seen, even if it is not statistically significant, of the quality of life. And the quality of life question is. The enzyme replacement therapy has, unfortunately, and this is one very sad aspect of the treatment, is not crossing the blood-brain barrier, which means patients have no benefit of their cognitive involvement. This, unfortunately, is a disadvantage or a handicap. To show you that, because I said the earlier you start, you avoid irreversible organ damage, that also older children or adults may have a benefit from ERT. I will show you this case. This is Heiko, and he is born from German parents. He was of normal height and weight when he was born, and the mother realized at the age of 3 to 4 months that he has a kind of stiffness of the shoulder, and she was surprised about that. He was in each other developmental milestones he reached in time without problems. With 2.5 years and 3 years, he had twice adenodectomy and T-tubes. With 3 years, developmental delay in language was diagnosed. And at the age of 3.5 years, he had an inner ear damage diagnosed. He needed ventilation tubes again and hearing aids. And the anesthesiologist actually had some idea of a lysosomal disease because he could not positioning him properly in the operating theater, and the diagnosis was done due to that at the age of 4 years with the urinary gag that was positive, enzyme activity on confirmation on genetic testing. What you can see here, between 4 and 8 years, the symptoms were increasing. So the body height on the growth curve went down. He had a continuous progression of the joint contractures. He had hernia, the cause phase. He had hepatomegaly all of a sudden. He had also at the age of 8 years then a heart involvement, so progressive disease. And here you see the overview of this patient from birth to 12 years of age when he started treatment, and you see the last blue box as the time before he started the treatment, and then 6 months, 18 months, and 5.5 years on treatment. On the pictures, you see that in 1 year he improved in the shoulder mobility. You see in the 6-minute walk test he improved also here. He improved or had stable results in the contractures of his joints, and also his face improved, and I will show you later. For sure he had also an improvement in the pulmonary function. But the most important for him, and this is what is seen here, is the height. He was born on the 95th percentile. He dropped down up to 12 years on the 10th percentile of growth. And then at the age of after 5.5 years on treatment, I will show you the pictures very soon, he was on the 70th percentile again. So he was growing up to normal. And here you see him between 16 and 17 years of age. He's now an IT specialist in a big hospital. He has an improvement of his joint contractures, his eyes, and also a stabilization of his heart, his ears, and no hepatosplenomegaly anymore. And to show you that also severe affected Hunter patients can have a benefit from treatment, you see here one of my patients at the age of 7 years and then 19 years, so 9 years of ERT. And you see him, even if he is severe affected with a severe cognitive involvement, he cannot eat alone, he has tracheostomy, he's sitting in a wheelchair, but you see him smiling, he's watching soccer, and he has a good quality of life. And take into consideration in literature, usually these severe affected Hunter patients would be without treatment, die at the age of 12 to 13 years. So in summary, MPS and mannosidosis, we have the 11 enzymes leading to 7 types of MPS with the storage of glycosaminoglycans in tissues. Mainly they are autosomal recessive, except MPS 2 that is X-linked. We have a multisystemic disease with dysostosis multiplex, so skeletal involvement, and with neurological and without neurological involvement. While in alpha-mannosidosis, we have the oligosaccharides that are stored. It is an autosomal recessive disease. It is rare for sure, but treatable. We have a multisystemic disease with dysostosis multiplex, meaning skeletal involvement, also in mannosidosis. We have mild, moderate, and severe forms, and we have in some patients neurological involvement. And in both diseases, what we have is that the earliest signs and symptoms are unspecific, with hearing loss, recurrent infections, hernia, and developmental delay. But in combination, it could lead to a diagnosis. And in conclusion, the best treatment of MPS and mannosidosis patients is the enzyme replacement therapy. For sure, it is not a healing therapy, but it is really improving the life of these patients, in combination with regular checkups and follow-up examinations to detect the life-threatening disease complications and the quality of life-reducing disease complications, and for sure an adequate symptomatic treatment, and this as early as possible. This is important to know. And I finish with another question. What is wrong? Mucopolysaccharidosis and mannosidosis need regular standardized follow-up examination. So what is wrong? Need a multidisciplinary team, specialists to be followed up, have life-threatening disease complications, have quality of life-reducing disease complications, have no treatment option. So what is wrong? Actually, everything is correct, beside the fact that they have no treatment option. We know we have the enzyme replacement treatment, and even if in your country there's no enzyme replacement treatment available, the regular follow-up examinations and then the symptomatic treatment is also giving a lot of impact on patients' quality of life and also the survival of these patients. Another question, what is wrong? Enzyme replacement therapy is available for all types. Stem cell transplantation is the treatment option for all MPS types and monocytosis. Symptomatic treatment is needed in all types and monocytosis. ERT is improving endurance. ERT is crossing the blood-brain barrier. So what do you think? I give you the result. For sure, it is wrong that enzyme replacement therapy is available for all types of MPS so far. We have for the MPS 3, we have no treatment available, also not for MPS 4B. For example, the stem cell transplantation is not a treatment option for all MPS types and monocytosis at the moment, only recommended for severe MPS 1, in some cases, in some countries also for MPS 6. And for sure, it is wrong that ERT is crossing the blood-brain barrier because the enzyme is too big and will not cross into the brain, which means the cognitive decline is not touched by the enzyme replacement therapy, but the physical situation, which also leads to a better general condition of this patient. And last question from my side before you are asking questions, what is correct? Early treatment is improving the outcome. Early diagnosis has a benefit for families and patients. MPS monocytosis may have anesthesia complications. Storage begins prior birth, and treatment recommendations are available. So all of these messages are correct, and these are also the key messages I would like to give you. And now it is your turn to ask some questions from your side. The one question is, what is the best option to diagnose these patients? Urinary gag, oligosaccharides, or dry blood spot test? And actually, in my point of view, it is the dry blood spot test, because they are so sensitive that you will not miss a patient. It is not specific enough, so it means you have false positive, and you have to test with the enzyme activity in blood or the genetic testing as well. But you don't miss a patient, but you can miss patients because milder affected patients have less oligosaccharide or glycosaminoglycan excretion in urine, or because the excretion is dropping down from the first year of life to adulthood. So you can have, with low gags, you can have, and oligosaccharides, you can miss some patients, but you can also have some increased gags, but no MPS, because it is just unspecific related to other diseases. Any further question? Should also adult patients should be treated although having already irreversible organ damage? Yes, and this is what I try to show you with a more attenuated case at the end. So even if you have patients that have already irreversible organ damage, what you can do is you stabilize these patients, and stabilizing is in progressive diseases a big benefit. So for me, if you can have you have a progressive disease and you stabilize the patient and they don't have any further progression, you have a big positive effect. And this is why also adult patients should be treated. And I have a lot of adult patients that I'm treating, and nobody of them stopped. So they are all very happy with the treatment and the stabilizing of their symptoms. Do we treat, next question, do we treat when symptoms are present, or do we start before symptoms are present? So this is what I already tried to explain. We try with the enzyme replacement therapy to avoid organ damage. So the effect is much better in avoiding than in correcting. So this is why the earlier you start the treatment, the better it is. Any further questions? when do you start to see sleep disorders? Actually, we see that very early. The cognitive involvement usually starts in preschool age, but what we see due to the adenoids and due to the enlarged tonsils and the recurrent infections, we see a lot of sleep disorders in small children, and not always a polysomnography is possible in these children, but sometimes it is enough to have to see to measure the saturation in one night, to see whether the oxygen is dropping down, and then to adapt. But also in young children, I would start immediately with diagnosis. I would start making some sleep test to see whether this patient has some apnea, snoring during night, and some desaturations, because the nightly hypoventilation is some part leading to daily hypoventilation and to death of these patients. ERT for alpha-mannosidosis could be considered useful both for pediatric and adult patients, and to be also associated with stem cell transplantation. So for sure, the alpha-mannosidosis treatment, the enzyme replacement treatment, is for children and also for adults useful, because you stabilize, as I said before, also adult patients. The hematopoietic stem cell transplantation was used in former times, but actually is not the treatment option of the first choice. Any further questions? No further question. So I would like to thank you for listening, to staying this hour with me, to listen about these rare diseases that are treatable. And I just want to finish with one sentence of a Belgian neurologist who said, "It will not be diagnosed if you do not think of it, and you will not think of it unless you know of it." So I hope you will keep in mind the MPSs, the mannosidosis, whenever you see a child and you have an idea of a metabolic or a skeletal dysplasia, test on MPS. There's a treatment available. Thank you very much for your attention, and I wish you a very nice day. Bye-bye.